A lot to cover. Oh, are you going to introduce me? Oh, okay, come on over, thanks.
Good morning, everyone. Please switch your cell phones and pages to silent mode. Our talk today is on orthopedics, sports medicine for the internist, and Diana Heiman is going to talk about that. She's the residency director for family medicine, Johnson City. Thank you.
All right. Good morning, everyone. Nice early, cold, rainy day, so at least it's not snow. I'm going to try and convince you guys that musculoskeletal medicine is actually important to you, which I think a lot of you are saying, oh boy, why do we have to have this lecture? I don't have any disclosures on financial side, or I'm not going to discuss anything that's unapproved. So I'm going to talk about how common orthopedic and musculoskeletal problems are in outpatient practice. My first topic actually is an inpatient topic, though. So we'll talk about pre-op assessment to a small degree. People to the OR quickly, really, is what we're going to talk about for hip fracture. And then prevention of thromboembolic disease in the post-op period. Talk about adhesive capsulitis, diagnosis and treatment. Talk about evidence-based treatment of knee osteoarthritis, obviously something that's very common in outpatient practice. And then look at evaluation of ankle injury and determination of whether an x-ray should be performed using the Ottawa ankle rules. Why is this important? Musculoskeletal problems do make up 10 to almost 30% of presenting complaints to primary care offices, and on the higher side for urgent care. So if any of you are going to go into primary care, outpatient practice, or urgent care, you will see lots and lots of musculoskeletal problems. And 8% of the questions on your ABIM exam are in the room ortho realm. So you can see here, it's just as much room and ortho as there is endo, diabetes, and metabolism. So obviously you see a lot more endo and diabetes and metabolism at this point because of the hospital work you do and everything, but it is actually a significant portion of your ABIM exam. And so we'll talk a little bit about shoulder osteoarthritis, and then ankle for sports injuries, trauma, and then in the elderly, the hip fracture. So you can see the breakdown of questions. This is the, wrong button. This is the number of questions there on each of these areas, roughly on the exam. So tried to cover things that I think that you'll see in the office and definitely have the potential to see on the exam. So we'll do a couple of cases and then some other questions throughout, depending on each topic. So case one, a 91-year-old female is admitted from the ED with an acute hip fracture from a ground level fall. This is a real case that I had on the hospital service last week. She comes from an assisted living setting, takes no chronic medications, and this is real. She really took no chronic medications. She has a normal mental status, no cardiac history. Most appropriate pre-op evaluation includes. How many are voting for A? B? C? D? E? All right, good. So risk factors for fracture, there's some calculators that you can use. The Framo Index predicts 2 years risk of hip fracture. Women's Health Initiative, obviously just for women. Hip fracture risk calculator. And so you can use those in your outpatient practice. And you can see that the Framo risk calculator has independent risk factors, 4 of them, age greater than 80, low weight, fragility fracture, so an insufficiency fracture or fracture from minor trauma after age 40, and having trouble getting up out of the chair, so needing to use your arms to get out of the chair. And then you can see the risk of hip fracture and also mortality from there. Then the Women's Health Initiative risk calculator actually is a little bit more detailed, and you can see all of the factors that go into the score there. And then you can see the 5-year fracture risk is based upon the score. So anywhere from 0.1 to greater than 5% chance of fracture, depending on the score there. Medications are also risky, and so looking at medications in the patients that you have, antidepressant medications actually significantly increase the risk with an odds ratio of 1.78. TCAs and second-generation antidepressants are actually both involved, so using an SSRI or an SNRI is not necessarily safer. It looks like the odds ratio is a little bit higher. Antipsychotic medication also, conventional is definitely riskier in this case. Benzos, definitely risky. We have lots of patients that end up on chronic benzos in this region, and people that have been on them for years and years and years and are very reluctant to get off in their 70s, 80s. Risk of any fracture, relative risk is 1.25, and of hip fracture, 1.35, and anybody on benzos versus no benzos. And sleep meds. So your nursing home patients on sleep meds, odds ratio of 1.66 for non-benzo, and then new benzo use, so within the last 30 days, odds ratio of 1.9. And then PPIs, this is also another one of those areas where people get on PPIs all the time for maybe not the strongest reason. They're put on in the hospital because they have something going on GI, and then they get sent home on it. Data is inconsistent, but definitely there are potential for increased hip fracture with PPI use long term. So there's been data for well over 10 years regarding decreased complication rate with early surgery. And so it looks like you guys are already on the ball with this, but I have seen issues in the hospital with all of the services where there are delays in getting somebody to the OR because they presumed need to do some evaluation. Really, surgery should only be delayed for evaluation, treatment of acute coronary syndrome, unstable arrhythmias, or any unstable respiratory disease. So there really is not a huge reason to delay surgery. And data that's out there now, it's even more robust. There are lots of meta-analyses that are looking at rapidity of surgery, and I'll give you a little bit more information in the next couple slides. The other issue that has been looked at is people on aspirin and Plavix, and those are not reasons to delay surgery, but again, the strength of evidence is lower on that, but they're not seeing additional complications because of bleeding. So who is too sick? People with unstable coronary syndrome, angina, acute or recent MI, they should be stabilized, obviously, before, and they may need to be risk stratified or intervened upon. Decompensated heart failure, so brand new onset, acute worsening, or New York Heart Association Class 4. Any significant arrhythmias that are not appropriately treated, so high-grade AV block, symptomatic or new ventricular arrhythmia, tachycardia with a rate of greater than 100, and that really is just getting it below 100 in order to get them to the OR, and symptomatic bradycardia. And then severe valvular disease, so severe critical AS and symptomatic mitral stenosis. So surgery within 24 hours associated with reduced pain, reduced length of stay in the hospital, fewer days of very severe and severe pain by a mean of 0.22 days, reduced hospital length of stay by 1.94 days, which is actually fairly significant and would be a huge cost savings. And then mortality in hospital at 30 days is lower if the surgery is performed less than 24 hours. And one study showed that it increased by an odds ratio of 1.32 for each additional 24-hour delay in surgery after that 24 hours. And then also 1.24 odds ratio, and so the 1.32 was the in-hospital mortality odds ratio, and 1.24 was the 30-day mortality for each 24 hours after the first 24 period. So reduction in in-hospital pneumonia with a relative risk of 0.59 and pressure sores with a relative risk of 0.48. And so that's with the early mobilization and not having people just lay in bed for the days waiting surgery when they can't get up and move. And then there was a meta-analysis that showed relative risk of 0.81 for early surgery. And the data was taken as it was presented in each of the studies. So some of it was 24 hours, some 48, and some 72 as a cutoff for early. And depending on, there was no difference looking at 24, 48, and 72 in that particular meta-analysis. But the mortality relative risk reduction was 0.81 just across the board when combining all of that data. So you guys answered this all correctly, but you should definitely do an EKG because pretty much nobody can go to the OR without an EKG, and get the patient to the OR within 24 hours if at all possible. So looking at the postoperative period, and this is taken right from a chest guideline PowerPoint slide. Risk of venous thromboembolism. It's hard to see from this angle here, but no prophylaxis. The risk is, or the prevalence is 2.8%, and this is with initial prophylaxis, just post-op, and then nothing after that point. This is with extended prophylaxis. You can see the rate goes down, and then with no prophylaxis at all, 0 to 35 days cumulative, then the risk is 4.3%. So you can see, sorry, this is all no prophylaxis. This is with low molecular weight heparin, just comparing it. So this is kind of baseline risk. And you can see 4.3% over days 0 to 35 is actually a pretty significant risk of DVT and PE. And you can see the risk reduction to 1.8%. With extended prophylaxis, which is now the current recommendation, it really reduces it to 0.65%. So it is a very significant risk. We've actually seen a case where somebody was accidentally sent to the nursing home without prophylaxis and actually came back within a week with a PE. So it definitely happens. And at this point, we really need to make sure that we're looking at this. So recommendations from the chest guidelines, and these are from 2012. Should use preferentially low molecular weight heparin, fondaparinux, or low-dose unfractionated heparin. This is kind of in the order of preference. And low-dose unfractionated heparin, obviously, you're going to have to use if you have somebody with significant renal failure. You can also use adjusted dose warfarin, aspirin, or pneumatic compression devices if somebody can't be on any of the other medications due to bleeding risk. So low molecular weight heparin is preference, and that's grade 2C to 2B. Patients receiving pharmacologic preference, they do suggest adding pneumatic compression devices in the hospital in order to increase the benefit, and again, that's grade 2C, so it's not high-level data, but while they are bedbound, they do recommend adding the pneumatic compression devices. And so the WE is the chest guidelines. Current recommendation is to use the thromboprophylaxis for 35 days, and you could see why, and that was that reduction in venous thromboembolic disease that was very significant over that 35-day period. And if you're starting low molecular weight heparin, you really want to start it either greater than or equal to 12 hours pre-op or greater than or equal to 12 hours post-op, rather than the 4-hour window because of increased bleeding risk, and that is a higher level recommendation. And so if the patient will have a delay of more than 12 hours in getting to the OR, give that first dose of Lovenox, and then start at 12 hours after surgery as well. If they're going to the OR less than 12 hours after arrival, then you do want to wait and only dose it postoperatively. You can use the oral options, obviously, and dabigatran or apixaban are recommended if the patient can't cooperate with injections or pneumatic compression devices, and those are just lower recommendations. On the preferential list, they still do have the grade 1B evidence. All right. Shoulder pain. So I'm sure you guys have seen 56-year-old diabetics in your office and in the hospital. So a 56-year-old male presents with shoulder pain and limitation of range of motion. He has a history of type 2 diabetes and hypertension. His exam reveals decreased passive range of motion, and he has a normal x-ray. So question number 1, which of the following statements about the diagnosis of adhesive capsulitis is correct? A, focal tenderness is a hallmark of adhesive capsulitis. Anyone think that? B, MRI is necessary to diagnose adhesive capsulitis. Anyone for that? C, patients with adhesive capsulitis have full range of motion in 3 planes. Anyone think that? And D, fasting glucose testing should be considered. All right, so not as many people answering on this one. Question 2, which of the following treatments are recommended for patients with adhesive capsulitis? Acetaminophen and NSAIDs, ultrasound, mobilization, intraarticular corticosteroids. All right, so a lot more uncertainty on this one, so we'll be able to answer all of these questions by the time I get through the information. Which of the following are risk factors for frozen shoulder? Male, gender, younger age, diabetes, all right, thyroid disease. Okay, all right. So adhesive capsulitis is, we don't know what causes it. There is definitely an association with diabetes, and that's very well proven. But basically, the patients come with progressive pain and loss of shoulder motion, and shoulder being the actual glenohumeral joint. It's, in most cases, completely idiopathic. We see the association with diabetes. It's not cause and effect, though, and so we don't know why this happens. There is associated rotator cuff pathology in many cases, and it may be just undiagnosed and kind of quiescent rotator cuff pathology that's found after the fact because someone got an MRI. Again, not necessarily cause and effect. But what happens is patients have pain and they stop moving, and then they get more stiff and more stiff and more stiff. Again, much higher incidence in diabetics and much higher incidence of recurrence and bilateral involvement in diabetics. And then the peak incidence is ages 40 to 70. So it's considered to have 3 stages that follow sequentially. A painful stage, so the pain comes and then they get frozen because they don't want to move because of the pain, and then there's a thawing or recovery stage, and they're, freeze and thaw. And the thawing stage actually can occur spontaneously, and in most patients does occur regardless of what you do, and the natural history is to recover within 1 to 2 years, typically with or without treatment. Some people are so bothered by the symptoms, though, that we do things much more quickly to try and resolve their symptoms. We don't always change that natural history, and about 10% of people will not regain full range of motion. Typically, it's not restrictive enough that it limits any of their normal daily activities, but about 10% won't get full function back. So diagnosis is clinical. You don't need to do any imaging. Again, the history, often just gradual onset of shoulder pain. There may not be any inciting event at all. It's often described as a deep ache and not focal tenderness. And they often have difficulty reaching overhead, reaching behind them, and those are the motions that are lost first. They will have very limited passive range of motion on exam, and they may have some associated rotator cuff weakness, especially if there's some underlying rotator cuff pathology that has not been diagnosed or evaluated. And as far as passive range of motion, when they're moving actively, they typically will have more pain, and so you want to make sure that you are actually having them fully relax and moving the arm. External rotation is going to be very restricted, and then abduction is going to be very restricted. And they may have so much pain that you can't tell when you're actually moving their arm if it's just pain that's limiting their motion, because they may tense up and resist you. And in that case, you can actually do a diagnostic injection, and so you can put in some lidocaine into the subacromial space, let it take effect, get the pain out of the equation, and then go ahead and retest. And then that you will actually feel a physical block. And typically they will get to about 45 degrees or less. they typically won't be able to get to 90. Again, they typically have non-specific point tenderness. They don't have point tenderness in, over the rotator cuff in any specific way. They tend to not have AC joint tenderness or biceps tendon tenderness. It's just a non-specific tenderness. And then again, other testing, strength testing and testing for rotator cuff pathology may be limited because of the lack of range of motion. So you can't get somebody into position to do a speeds test. You can't get them into position to do a Hawkins for impingement if they can't get their arm into 90 degrees of forward flexion. And again, x-rays can be helpful if you're looking for associated pathology. And specifically what you do want to look for is a complete rotator cuff tear with actual elevation of the humeral head within the glenoid. And then you can see the same types of limited motion. You can also see the same types of limited motion if someone has profound glenohumeral osteoarthritis. And so those are the things that you want to look for. But really, you're not going to see anything specific for adhesive capsulitis on your imaging. So here's a nice breakdown of differential diagnosis. And obviously, this is something just for reference for later. But giving you distinguishing features on exam and diagnostic tests so that way you can help to differentiate between the different etiologies of shoulder pain that you may be considering. So treatment, not a lot of data. There's not been a ton of high-level studies looking at what to do. So a lot of it is really empiric and just expert opinion based and what we've done over the years. So typically acetaminophen NSAIDs, you can use an oral steroid course in either a burst or a taper, and that does have evidence for reducing pain acutely, not any long-term evidence for reducing pain. Steroid injections, the patients often have so much pain they can't do physical therapy. And aggressive physical therapy will make them worse because then it will cause more pain. And then they will backtrack and get more stiff. And so it becomes like a vicious cycle at that point. Home exercise program or physical therapy depends on the patient's preference, the patient's insurance status, because obviously if they have no insurance, you can't send them physical therapy. It's incredibly expensive, and sometimes patients will have a high copay for physical therapy as well. It may be upwards of $40 a visit, and they may not be able to afford to go to physical therapy either. Encourage movement, do not immobilize. What has also been shown to be helpful in the literature is to do a steroid injection before starting physical therapy, and that's the same philosophy as the diagnostic injection. You're reducing the pain, and if you do that, there has been less super acute pain reduction, but longer term benefit versus the oral steroids. So injection, you do get a longer benefit and a little bit less up front. Oral steroids, you get more benefit up front and less long term. And you can either do a subacromial injection or an intra-articular injection. The data that's out there from studies actually shows either to be beneficial. So I'm sure most of you are much more comfortable doing a subacromial injection than an intra-articular injection if you do injections at all. And so that is absolutely fine to try, and that is actually what I do for patients. They almost universally will not be able to do physical therapy unless you inject them beforehand, just because of the amount of pain they have as they start moving. So if they fail all of those things and they're terribly bothered by their limitation in motion, and really this is for motion, not for pain, you can do a radiographically guided capsular distension where they inject a bunch of saline and lidocaine into the joint to just stretch it out. And then finally, manipulation under anesthesia, or the orthopedic surgeons can do a capsular release. And again, this is not for pain reduction, it's really for the limitation in motion, and there's something specific that they need to gain in order to be able to be functional. This is definitely a condition that you should be treating in your office. It does not require an orthopedic referral whatsoever unless you're concerned about them needing some further intervention or the patient not getting better, or if you have a question that this is not the right diagnosis. This really is something that should be managed in the primary care office. All right, so back to those questions. Which one of the following statements is true about adhesive capsulitis? So focal tenderness is a hallmark. Anyone for that? MRI is necessary to diagnose it. Patients with adhesive capsulitis will have full range of motion in all three planes. Fasting glucose should be considered. All right, much better answering on that one. So yes, fasting glucose should be considered just given the association with diabetes. All right, for number 2, choose all that apply. So which of the following treatments are recommended? Acetaminophen and NSAIDs? Yes, yes, okay. Ultrasound? Mobilization? Intra-articular corticosteroids? All right, so yes, A and D for that one. Pain control and then injection as well. Case 3, which of the following are risk factors? Choose all that apply. Male sex, younger age, diabetes, thyroid disease. And I didn't cover it, but thyroid disease actually is also a risk factor. Not so robust as diabetes, but thyroid is. All right, so moving down into the knee. What's the most appropriate initial treatment for knee osteoarthritis? So, and this can be multiple answers for this as well. NSAIDs, Tramadol, low impact exercise, aquatic therapy, all of the above. Yeah, all right. So here's a actual one of my patients from when I was in Connecticut. And she was actually a 40-year-old woman at the time that this was obtained, had no pain prior to about a month before this x-ray was taken. And you can see there's very significant compression of the medial joint space. She's got big osteophyte here, small osteophyte there. Same thing on this side, osteophyte formation. You can see the subchondral sclerosis as well here on the medial aspect. You can see it better on that side than the other. You can see she's obviously morbidly obese with all of the extra soft tissue, so again, another risk factor. And you can't see the subchondral cyst, but that's the fourth finding that you'll see on a plain film. So joint space narrowing, osteophyte formation, subchondral sclerosis, and subchondral cyst formation are the 4 things that you'll see on plain x-rays in osteoarthritis. So I'll go through each of the common things that you would use to treat osteoarthritis and present the data individually, and then have a little algorithm at the end to kind of summarize. So acetaminophen, the data on this has actually gone back and forth and was very, very favorable as a first-line agent probably 5-7 years ago, and then now it's kind of backed off as they've looked a little bit closer at the data. The majority of the trials last only 6 weeks. The effect does come rapidly within 6 days. But on the other hand, NSAIDs offer faster onset, better overall pain control, and equal function. So the bottom line is the NSAIDs are better. And the AAOS guidelines are the American Academy of Orthopedic Surgeons, and this was just released as an update last year. And they cannot recommend for or against acetaminophen due to the lack of high-quality studies showing benefit over placebo. And the American College of Rheumatology also has a set of guidelines that are very similar to the American Academy of Orthopedic Surgery guidelines as well. So they put the acetaminophen into the category of may try it. NSAIDs, all of the varieties are effective in the short term. Again, long-term data is unknown because they have not looked at studies over a long course of time. Atodolac, which is Lodine, combined with acetaminophen is possibly better than atodolac alone. That's one individual study. Atodolac tends to be a little easier on the stomach. It's not on the $4 list, and it's not always easy to find or get for people. But it is one that I've had good success with, especially when people have had GI upset from other NSAIDs. COX-2 should be used with caution because of the cardiovascular issues. Naproxen is safest for anybody with cardiovascular disease. It does, though, tend to be difficult on some people as far as GI side effects. Topical ibuprofen cream, which is not readily available and less compounded in this area. And diclofenac, either cream, gel, or solution, are effective with fewer side effects. I've found lots of benefit from using these. The Medicare plans, many of them will cover the diclofenac gel, but not the patches, and not lidoderm patches anymore either. So this is a good option. You can also send them to a compounding pharmacy to get ketoprofen compounded, and so that can be an option as well. Not the same kind of robust data, but it is something that's available, and it is covered by Medicare Part D. AAOS guidelines strongly recommend NSAIDs as first-line therapy, and the recommendation from the American College of Rheumatology is not quite so strong, but they do recommend NSAIDs as first-line. So other medications, and then this is another place where the data has shifted recently. Tramadol was just kind of an option as a recommendation previously. Their effect is improved when used with acetaminophen. The benefit is modest. It's equal to diclofenac, oral diclofenac, and it's greater than placebo. The guidelines have actually shifted and say it should be used first line along with NSAIDs, where acetaminophen has actually fallen out of favor because of the lack of placebo-controlled data. So this is an area where recommendation has been pushed up recently. The American College of Rheumatology also has recommended its use as well. And then opioids are recommended against using, should not be routinely used unless somebody really cannot tolerate NSAIDs or Tramadol for other medical reasons. There's only a small to modest benefit in pain reduction and improved function, but obviously the high rate of adverse effects, especially when you're considering that we're using this in elderly folks that will typically have more side effects from opioids as well. Topical capsaicin, regular use may decrease pain, but most people have significant side effects from using it. So I've seen some people get excellent benefit from it, and most people try it once and say, oh, this is awful, because it burns when they put it on. So you really have to encourage them. They have to use it over time in order to decrease the topical sensation, but it can be effective. So physical therapy exercise, cornerstone of treatment. Lots and lots and lots of great data on all different types of exercise. Land-based exercise in the short term equals NSAIDs. So doing land-based exercise as opposed to aquatic, so water exercise, can give people the same benefit as using NSAIDs without having any of the negative effects. Exercise and manual joint mobilization, so mobilization of the joint to increase range of motion with physical therapy is greater than exercise alone or strength training alone. So using some of the other techniques that the physical therapists use can be beneficial. Lower extremity strengthening. Oftentimes, patients with osteoarthritis, because they stop doing as much activity because of pain, will then get secondary weakness. Oftentimes a lot of glute weakness, and so they will have abnormal gaits that will then potentially increase pain in other locations, specifically the low back. Aquatic exercise is beneficial in the short term. There's no long-term data. Patients love it though. The water is warm, and so the warmth actually helps improve range of motion, and it soothes the pain. So it's definitely something that patients really like, and we can do it through physical therapy here. You just have to specify aquatic therapy or water therapy, hydrotherapy. Hydrotherapy equals land-based therapy, especially in the short term. Walking is wonderful. So just getting your patient out and walking. Doesn't have to be anything special, just right outside at the mall, wherever is safe for them to do that. Adding a group class to home exercise program is better than just home exercise program alone. And there is something about the support with the group. So getting them to kind of commiserate with each other and see that other people have the same symptoms and hear what works for other people can be beneficial as well. Community-based exercise improves pain and function, and so again, that the involvement of others to get other ideas and just to have that support. Ice massage is beneficial. Ice packs are beneficial. Heat is not in studies, but just anecdotally, patients like heat a whole lot more just because it's more comfortable. Ice is often incredibly uncomfortable for some people. The American Academy of Orthopedic Surgery strongly recommends strengthening, low-impact aerobic exercise, neuromuscular education, and then engaging in physical activity based upon national guidelines, so 30 minutes at least 5 days a week of aerobic exercise. The ACR strongly recommends did you have something? Proprioception. So working on proprioceptive re-education. And so again, anytime that there's some sort of injury or a decrease in function, proprioception is the first thing to go. And so that's what neuromuscular re-education, yeah. So the American College of Rheumatology also strongly recommends exercise as first-line therapy. So cornerstone of what you should be recommending to your patients, get them up, get them moving. This is by far best evidence. Weight loss. As you can see with that patient whose x-rays I showed you, the AAOS has a moderate recommendation encouraging weight loss for all patients with OA and a BMI of greater than or equal to 25. The ACR recommendation is a strong recommendation to encourage weight loss, and anybody that is overweight is how they state their recommendation. Steroid injections, also something that's kind of fluctuated over the years. You will see if you have a patient and you're trying to get them to qualify for viscosupplementation or hyaluronic acid injections, almost every insurance company will make you have the patient go through steroid injections and fail them before they will approve hyaluronic acid injections or viscosupplementation. That is not an evidence-based decision. It is a monetary decision by the insurance companies, and it's pretty universal. Viscosupplementation is much more expensive than a steroid injection. Again, the data is not robust. It's just not something that's been studied very well. It's been anecdotally done in expert opinion for years and years and years, and so that's what we do. There is definite short-term benefit, and some patients can get long-term benefit as well, but it's very patient-specific. It's not universal that everyone will respond. Some patients never respond to steroids at all. They get 2 injections and don't have any response. We don't keep doing it. We'll move on to the next course of therapy. There was a meta-analysis that was done that showed it was better than placebo with an NNT of 4.4 at 4 to 6 months. So that really is a very good NNT. But again, it's not, we don't have a whole lot of really robust data. Can't predict responders, and safety is established for 4 injections per year over 2 years. Some of the other intricacies or issues, different steroids have not been studied head-to-head. There's no data on what amount of steroid, what amount of anesthetic to use. The basic guidelines are dilute the steroid at least in half by your anesthetic. Particulate steroids, so the ones that are cloudy and you have to mix, tend to have a higher chance of steroid flare afterwards, whereas solutions like dexamethasone have a lower chance. Again, this is all really more expert opinion. It's not that there's this great robust data. I will say, knock on wood, that since I changed to using dexamethasone for my injections about 10 years ago, I've never had anyone have a steroid flare. Whereas with Celestone or Depomedrol, you were seeing it fairly frequently, commonly. The Marcaine is considered to be chondrotoxic. So if you have somebody that's young that does have pretty significant remaining chondral surface, you really don't want to be using that. And so it's really kind of a dicey issue. If the younger the person is and the longer you want to try and get them to their joint replacement, you definitely want to avoid a lot of steroid and a lot of Marcaine, specifically the Marcaine. So it's not quite as straightforward as maybe that you were taught previously. AEOS is unable to recommend for or against intra-articular steroids due to the lack of high-quality evidence, and the ACR also has it as a lower level, give it a try recommendation. So hyaluronic acid, there's lots and lots and lots of studies. Most of them are industry-sponsored, and there is publication bias. So negative trials have been suppressed, and that's where this becomes a little bit more dicey as well. So this was a higher recommendation 5 years ago and now has changed. And when the AAOS guidelines came out last year, this was a huge controversial issue for them to recommend or to say that there's insufficient evidence to recommend for viscosupplementation. It was very politically incorrect for them to do that because their guidelines definitely direct a lot of insurance coverage for things, and when this happened, some of the insurance companies then would say, oh, well, we're not going to pay for that at all. And so then what's their option? Their option is to go have a joint replacement. So there's definitely a little controversy about them releasing these guidelines and then potentially saying more people should have joint replacements. So take that for what it's worth. It is still recommended by the American College of Rheumatology, and the Cochrane guideline still says that this is beneficial predominantly 5 to 13 weeks after injection, and does have better long-term outcomes. It's more effective earlier, so this is what you really want to be using on your young people with osteoarthritis that you want to get years and years and years until their joint replacement, because you don't want to be ruining them early with steroid and marking. Euflexa, all of these are essentially from coxcombs, so the little thing on the back of the head of the chicken. So people with avian protein allergies can't use any of the viscosupplementation except Euflexa. Glucosamine and Chondroitin. How many of you recommend this to your patients? Nobody. Okay. All right. This has also fluctuated through the years as well. Many studies, a lot of variable results. And essentially, when it boils down, the only positive results with glucosamine have been with the DONA brand, D-O-N-A. It's from Netherlands, Sweden, somewhere in Europe. It is available here, and it typically was available as a packet that you had to mix with water. I believe there are pills now. But the only positive data in the literature is actually specifically from that brand. Anytime they've done studies with any other brand, the data has not shown benefit. And again, the Cochrane reflects that. It shows it doesn't work to reduce pain or increase function at 2 to 3 months, except DONA brand, which is by Rota, is the pharmaceutical company, R-O-T-T-A. The dose is 1,500 milligrams of glucosamine daily. What I recommend for people is give it a try for 6 months. If no improvement, stop. If then they see that their pain is worse, okay, well, it probably was working. It is a gradual onset of action if it does work for somebody. I do recommend the DONA brand. It is expensive. It is available, I know, at least at Walgreens. I'm not sure about CVS, but I know Walgreens carries it. Mm-hmm. Oh, usually it's going to be upwards of $30 a month. So it's not horrifically expensive, but it depends on, when the patient's getting their prescriptions at the $4, $10 mark, or they have, a $2 copay through their Medicare Part D, it's going to be a big difference to pay $30 a month. So, yeah. If you are recommending any other products, make sure they all have different glucosamine content, so make sure they are getting at least the 1,500 milligrams. And whenever I'm recommending any kind of supplement, I always want to make sure that the patients are using a brand that's USP verified. So the biggest company that has done that that's widely available is Nature Made. And so that's where they've had independent verification that their products contain what they say they contain. And I'm sure you guys heard within the last few months that Walgreens had a big issue where they looked at their supplements and vitamins and they were way off on what they contained. And so they had to pull some from the shelves, and one of them was their glucosamine. So, so that's the only other caveat when you're using anything that is not a pharmaceutical grade. prescription product, is to make sure that they're a reputable brand. Chondroitin studies, on the other hand, have been very small, very limited quality, so there's never been really any robust data on chondroitin. They tend to be combined together with or without MSM or SAMe or any of that. None of them really have any robust data. And AAOS doesn't recommend their use. ACR says it's a lower level, you can give it a try, but it's not a strong recommendation. Bracing and orthoses. Knee bracing, and these are medial unloader braces. So basically, when you get compression of the medial joint space, you get that nice bow leg appearance. When you get lateral, you get the knock-kneed. And so basically what they're trying to do is put the patient from this position back into a more straight position. And so they're putting pressure to open up that medial joint space. And they're very cumbersome. They're not well tolerated. And they will have small improvement in pain and function, but just not so robust. Heel wedges may have a small benefit. Neoprene sleeves, really no significant benefit. And again, compliance is an issue. You can do knee taping, and that can be more beneficial. But again, a physical therapist typically has to teach them how to do that. Alternative treatments, TENS, maybe benefit, poor quality studies. Tai Chi, likely beneficial, improving pain, function, quality of life, and walking time. So that's actually good. Also prevents falls in your elderly, so that's a wonderful recommendation for somebody. They do offer Tai Chi classes a lot at senior centers. Acupuncture, probably not clinically significant. Topical arnica, there's not a lot of data, but there was an open study showing benefit and safety. Magnets, may be suggestive of benefit, but again, small number of studies in patients. SAMe, poor quality, inconclusive evidence, don't recommend. Therapeutic ultrasound may be beneficial, but again, low quality studies. Things that are not effective, joint lavage and arthroscopic debridement. So if you have a orthopedic surgeon that wants to take all the patients to clean out in the OR, I wouldn't refer people to that person. Now, if they have a symptomatic tear and they're literally getting locking or something, that's a different story, but just joint lavage or arthroscopic debridement for osteoarthritis without locking or mechanical symptoms, not beneficial. So just kind of a summary, start with NSAIDs or Tramadol and exercise. Again, exercise, and then that goes along with weight loss as well if there's a BMI greater than or equal to 25. You can consider bracing or heel wedge if somebody doesn't want to have injections or something more significant. Again, just warn them, small benefit and very significant compliance issues. Consider steroid injection, and then if they fail that, consider hyaluronic acid injections, and then if they're failing everything, refer for joint replacement. Not an arthroscopic washout. There's actually not any Cochrane or recommendation specifically on that yet. There's actually HeyPad is one of the people that do the inserts in the shoes, and they have some copper products that they tout, and they have some of their own data that they show at our conferences, but I don't know of any high-level data that shows there is a benefit for that. All right, so most appropriate initial treatment includes all of the above. Yep. All right, so just a couple slides on ankle injury because I know I'm right at time. So I rolled my ankle and heard it crack. What is the likelihood that it's fractured? Does not correlate. Now in the knee, if you hear a pop or feel a pop or hear a pop, highly correlative with significant injury, but not in the ankle. So it's not diagnostic. The likelihood ratio is less than 1. So everyone remembers their ankle anatomy. You've got the deltoid ligament on the medial aspect, the syndesmosis here, the tib-fib ligament, anterior talofib, calc fib, and then the posterior talofib is sitting up buried underneath there. So lateral ankle sprains are 88% of injuries. Medial are much less. Fractures are even much less. So really, lateral ankle sprain is going to be where the money is. Grade 1 is no instability, minimal swelling pain. Grade 2, mild to moderate instability and painful ambulation. And grade 3 is a lot of instability, so basically the ligaments are completely ruptured. Severe pain, a lot of swelling, unable to ambulate. So who has heard of the Ottawa ankle rules? All right, so roughly a third or so. So these are validated. They've been around for a long time. So in your office or the emergency room or urgent care, you want to order ankle films, and these are ankle, not foot. So ankle films, if there's point tenderness over the posterior aspect of the malleoli. So you want to look at the distal 6 centimeters of the posterior aspects of medial or lateral malleoli, and the reason you want to look at the posterior aspect is because the ligaments attach on the anterior aspect, and so if you touch there, it's going to hurt because of the sprain. So again, inability to bear weight, which is 4 steps, both immediately and in the emergency department, or your office or urgent care. And again, these are the locations that you want to palpate, so posterior aspect here and here. The foot rules also include base of the fifth and the navicular. Again, for those, you want to order a foot film, but the malleoli tenderness or the inability to bear weight with the pain more in the ankle, you want to get ankle films. Sensitivity is very, very high, 98 to 100%. Specificity is low, so you're going to get extra x-rays, but you're not going to miss fractures. Positive likelihood ratio is 1.4. All right, so we talked about how common orthopedic and musculoskeletal problems are, and it's 8% of your ABIM exam. Talked about evaluating a patient, getting them to the OR after a hip fracture, and thromboprophylaxis, why that's important post-op. Talked about diagnosis and treatment of adhesive capsulitis, evidence-based treatment of knee OA, and the Ottawa ankle rules. Thank you. There's some references here, and so you guys will have access to the slides. Any questions? Yeah, the most recent. The AAOS guideline frowns upon the partials. So the most recent data recommendations don't say that they're beneficial. I have seen patients go years, if they've had a meniscectomy as a young person, they really have preservation elsewhere. But so just a medial hemi joint replacement. So data doesn't back it up, but some people want to still do it. Typically, it's going to be the same thing every 3 months. Yeah. Really, what you're trying to do is delay it. If they have knees that look like that, they're going to end up with joint replacements, especially at 40. And that patient did end up with, she tore her ACL on her less painful knee and ended up having a joint replacement on that side because you can't do an ACL reconstruction or repair on somebody that is, has arthritis like that. So, and then she ended up getting it done a few months later. But yes, so what you're trying to do is delay the need for joint replacement. There is no fix for this because it's literally the articular surface is gone, and there is nothing that we can do at this point to replace the articular surface. Well, yeah, sure, because they wear out. So if you've got someone that's 40, I mean, she's going to need another knee before she's, done with life. So, yeah, the longer you want to try and get somebody closer to 60 before you're doing the knee replacement, just because of the longevity of the actual replacement itself. And they do last longer, but depending on what the activity level is, you're going to wear it out faster if you're a much more active person and you're up and doing a lot of physical activity on them. They're not made to play tennis, do cutting, those types of things. That you really have to do more inline. They, in many cases, take the ACL and PCL out as they do the implant, so it's not the same kind of a stable knee that you had. Yeah, 20 is kind of where we're seeing them now on the high side. Less if you're abusing it. I use 8 milligrams, so they come in 4 milligram per ml vials, and I use 2 of those. So my typical large joint injection is going to be 4 cc's of lidocaine, 4 cc's of marcaine in somebody that has a knee that's going to be replaced at some point, and then 2 cc's of dexamethasone. And I use that same for all large joints, and large joints would be SI joint, greater troch, knee, shoulder. I do intra-articular hip too, but with ultrasound guidance. Mm-hmm. Yeah, and that's a big controversy right now. Probably the trend is going to be towards pushing more for ultrasound-guided injections only as far as payment and whatnot, because the studies really have shown inaccuracy of needle placement. Having said that, I do SI joints under ultrasound guidance, and I do intra-articular hips under ultrasound guidance. I haven't changed to do every single injection under ultrasound guidance, but if somebody does respond poorly to an injection, then I will bring them back and do it under ultrasound guidance. But yes, the trend is towards moving that way. It's time-consuming and it's costly, but the data is definitely showing that that's probably the best way to go, unfortunately. For No, portable in the office. Yeah, I have an ultrasound I do right in the office. Yeah. Mm-hmm. Well, yeah, because you're billing out 3 times as much, and yeah. Yeah, and actually, Medicare as of January 1 just bundled the codes, and they really reduced the payment quite significantly for it as well. So it's caused people to be, because people were using it also as just a money generator as well. So it's, one of those fun things where reimbursement has been cut back significantly as of January 1. But yes, I think as far as accuracy, the machines are about $30,000 for a really nice portable machine, and that's really because of the cost of the probes. You can get one a little cheaper, probably $20,000, and you can definitely get used machines that are still very high quality. They do demos where they use it for a conference, and then they can't sell it as new. So that's a great way to get a machine. But I think the use of ultrasound in medicine is growing rapidly just across the board. All right, thank you very much.